So I will be talking on diabetic kidney disease and screening for it and what interventions we can take to reduce the progression of diabetic kidney disease in the next 10 to 15 minutes. So as Sir said earlier, perhaps we are better at screening for diabetic kidney disease because the microvascular complications are more well known than liver disease associated with diabetes. But this is just to refresh your knowledge and make sure that we are taking the appropriate interventions after we do the basic screening and whether we are doing the screening properly. So just an overview, kidney disease is said to affect nearly 40% of all diabetic patients, and here in Sri Lanka, given the recent health statistics, CKD is the 4th leading cause of hospitalization and the 6th leading cause of hospital mortality. And several single center studies done in Colombo, Kandy, diabetes has been found as the leading cause of chronic kidney disease. So there is a significant impact on public health, leading to a lot of increased healthcare costs, both directly, and because these patients stop working, there's loss of productivity, there's a lot of indirect costs as well. So it is very important to screen and catch early and do the appropriate interventions to prevent progression. So there are 3 questions we need to ask ourselves when we are screening patients for diabetic nephropathy. When do I start screening my patient with diabetes? How often should I be screening him? And with what should I be screening them? So the general recommendation is we start screening diabetic patients for kidney disease. If they are a type 1 diabetic, we usually start from 5 years from the start of their diagnosis. While in type 2 diabetics, we start from the very onset, from the very first time that they are diagnosed with the diabetes, we have to start the screening. And any diabetic with hypertension, once again, we have to screen them from the very onset of the disease. So once we decide when to start screening, we have to decide how often we do it. So this depends. If the patient is not having any kidney disease at the time of the diagnosis, we routinely surveillance them once a year. But I'll explain this later on as well. If they do start developing signs of kidney disease, we need to increase the surveillance frequency. So moving on to with what are we going to surveillance these patients with? So there are 2 tests that is now recommended. One is the spot urine albumin creatinine ratio, and the second test is a serum creatinine with a calculated eGFR. So I'd like to talk a bit about the urine albumin creatinine ratio. So this is basically a random spot urine sample, and it has replaced really the 24-hour collections that we used to do in the older days, because that was very cumbersome and it really adds little to the spot UACR. So that is really now gone out of favor. Unfortunately, we don't have this freely available to us in the government sector. So the one that we do have is a spot urine albumin. But the difference between a spot urine albumin and a urine albumin creatinine ratio is that the urine albumin is more susceptible to getting false negatives and positives. So if the spot urine albumin becomes positive, we have to end up doing a UACR anyways. So that's why they recommend might as well do the UACR in the first place rather than doing 2 tests. So the cutoffs that are given is a normal UACR is when the level is less than 30 milligrams per gram of creatinine. A moderate elevation is when it's between 30 and 300, and a severely elevated is when it's more than 300. So despite it being a better, with less false positives and negatives than a spot urine albumin, we have to be aware of these caveats when we are doing a UACR as well. So I mentioned a few circumstances that may elevate the UACR when the patient is not actually having kidney disease. So if they've had vigorous exercise within the last 1 day, if there is having an ongoing infection or fever, a congestive heart failure or very poorly controlled blood sugar or blood pressure, and if the patient is menstruating, we should avoid doing a UACR in these circumstances. So that's the first test we do for screening, and alongside this we should be doing a serum creatinine and calculate the eGFR as well. So based on these 2 tests, we can put the patient somewhere on this table. So you can see from the two green boxes, that's the best case scenario. Your diabetic patient, they have a normal EGFR that's more than 90, and they have less than 30 milligrams per gram of protein in the UACR. So they are really free of diabetic kidney disease at the moment. But that doesn't mean we forget about them. The minimum acceptable standard is that we continue to screen these patients once a year with these two tests. And as things progress, you can see how the severity of the diabetic kidney disease builds up. So if the proteinuria starts increasing or the EGFR starts dropping, you can plot your patient on which stage they are in, and thereafter decide how often. So the number indicated in this table is really how often we should be doing the screening, the surveillance tests, and then whether we are going to treat or refer this patient for more specialized input. So this is basically an overall summary of where, once you do the two screening tests, where you're going to plot the patient and what you're going to do with your patient. So that is the fourth thing I want to talk about. That is what we are going to do once we find, or even in the stage 1 when there is no diabetic kidney disease, what steps we should do to prevent progression or prevent the onset even. So the first step obviously is having good glycemic control. All the microvascular complications of diabetes is very closely linked to your blood sugar level and your blood sugar control. So though these targets are really patient specific, generally we say that the HbA1c of 7 or less should be our target to prevent microvascular complications. So the second thing is good blood pressure control, and this is closely linked with reducing the onset and progression of nephropathy. So we want our pressure, depending on your patient, this might change, but generally, in general, we want it to be below 130/80. So those two things are vital and should be considered in all your diabetic patients. The third thing is the use of special drugs that we can use to prevent the progression of your diabetic kidney disease. So the first group of drugs that I want to talk about are the ACE inhibitors, or the angiotensin converting enzyme inhibitors, or the angiotensin receptor blockers. So we use ACE inhibitors or ARBs if they can't tolerate an ACE inhibitor, if there is even a moderate increase in the albuminuria. So say the patient is not hypertensive but diabetic, and we found in our UACR that he is having a range between 30 and 300, then even without the absence of hypertension, there is an indication to start a ACE inhibitor for this patient. And it is obviously more strongly recommended when the UACR is more than 300, or if the EGFR has started to drop below 60. However, we don't recommend starting an ACE inhibitor or an ARB in a diabetic patient who has normal blood pressure, normal UACR, and a normal EGFR. So it's not really recommended as a primary prevention drug, but only to be started when there is mild proteinuria. In the guidelines, they say the combination of the two drugs, that means ACE inhibitor plus ARB, should be avoided because the risks that it brings far outweighs the benefits. And this is something we need to consider. I think we should use the maximum tolerable dose of the drug. Because quite often we are good at starting the ACE inhibitor, but we don't increase it to the maximum tolerable dose, which will bring the best benefit of the drug. So by maximum tolerable dose, I mean that the blood pressure is, the patient does not become having symptomatic hypertension, we want pressure doesn't drop too much, and that they don't develop hyperkalemia. And also that sometimes we get worried when we start the ACE inhibitor and the patient's creatinine goes up. But we must keep in mind that there is what we call a permissive rise in creatinine once the ACE inhibitor is started. And we can allow even up to 30% rise in creatinine without stopping the drug. If it goes beyond, we need to consider stopping and trying to see whether there's underlying cause for that. So even if the creatinine goes up, just see if we can continue it if it's within this 30% range, and try and get the patient up to the maximum tolerable dose. So ACE inhibitor or ARB is a must. The second group of drugs are the SGLT2 inhibitors. So these also have been definitely proven to reduce the CKD progression. And not only that, because diabetic kidney disease is closely linked with cardiovascular mortality in diabetic patients as well. So it has a dual action in reducing the cardiovascular events. So an SGLT2 inhibitor should be considered in any diabetic patient whose EGFR has dropped, but even up to 20, we can start it. And the urine albumin, if the urine albumin creatinine ratio is high. So this is level A evidence now, and it is strongly recommended. So if the SGLT2 inhibitor is started and the EGFR continues to drop, they say even below 20 we can continue it until the patient goes on to dialysis or ends up needing a transplant. So it is a very important drug that we need to consider along with our ACE inhibitor, whether we are using it enough in our diabetic patients to reduce the risk of reduce the progression of the kidney disease. So I'll just finish off by summarizing with this slide. Remember to ask yourselves these 3 questions. When do I start screening my diabetic patient for kidney disease? Once I start, I be doing it? And then with what? The spot UACR and the serum creatinine and the EGFR, and then plot your patient on that table to decide which stage he is at. And then ensure that you're taking the necessary remedial action, including good glycemic control, good blood pressure control, and is he on the right drugs to prevent this progression and for the patient to not end up with end-stage kidney disease. So this is the main reference I used for my talk, and I'll stop there. Thank you. Thank you.